Hello, everybody. Welcome on this live webinar. Fantastic that you took the time to be here with me today. Also, welcome to all the colleagues who are watching this webinar in replay version. Because as usual, at the end of this webinar, you're going to receive an email with a replay link to this webinar. So if you would like to watch it again, with pleasure. So this webinar is a little bit different than my previous webinars. It's a Q&A webinar. So the success of this webinar not only depends on myself, but mainly depends on you and your questions, because the purpose is that today, during this, let's say, 1 hour session, that I guide you, help you to try to solve some problems you might have regarding to clinical reasoning and diagnosis and treatment. Okay. In the meantime, I see some of you appear in the chat, so that's very nice. But I'm curious. I'm very curious. And if you watch now, then if everything is okay, you should be able to see a poll. And I would like to know who you are. Yeah, who is here for the first time? Who already followed my webinars, but not a live course yet? And who already followed a live hands-on course with me or one of my colleagues? Well, that looks pretty interesting. Yeah, about 50% of you is here for the very first time. So, welcome. 26% of you are not here for the first time, but you already followed some webinars, but not a live course yet. And about 26%, 25% of you already followed the live course. So that's really, yeah, that's a nice mix. That's how I like it. Well, as I said, I'm looking forward to your questions. Yeah, so I'm just going to close this poll now. Okay, reset poll, because I have to do everything in here. I'm alone over here, so I hope the technical part functions pretty well. Voila. I go back to the chat. Yeah, and in the meantime, I see that Paolo from Italy is here for the first time. And Trevor, yes, Trevor, I know you digitally. And other colleagues from Malaysia, welcome. Okay, when you registered for this webinar, you had the opportunity to already ask a question before, and that's of course interesting for me, because then I can prepare some things. And I have good news, and I have some less good news. Let me look at some of the questions I received from you, and I'm going to quote one question, a question about implant designs in total knee replacements. And let me put the screen a little bit bigger. Voila, here I am. Implant designs in total knee replacement, why ACL is not retained during arthroplasty and only PCL is retained. Bicruciate ligament retaining has been introduced now, but when will it come into practice? Well, that's a very nice question, but unfortunately, I don't have an answer. Because we focus entirely on clinical reasoning, diagnosis, and conservative approach of soft tissue lesions. Once the patient got surgery and you're in a revalidation program, then I have to be very honest with you. I know nothing about that. This is not my cup of tea. This is not my core business. Here, the room behind me, the clinic of my wife, she's very good at revalidation, but not me. So sorry. Somebody else asked, can you talk about the foot and the ankle after 3 malleolar fractures 6 months after operation? Well, same answer. This is not my cup of tea, but What are you going to do with Cyriax techniques with such a patient? Then the answer is very simple: nothing. Nothing. This is not an indication for Cyriax techniques. Then it's very interesting to look in different directions. And certainly with those kind of post-operative patients, I believe that one of the treatment options which is interesting are, for instance, a kind of Mulligan mobilizations. Mobilization with movement can be, for those patients, I think, very interesting. Okay. But of course, I received more questions, and let's go through some questions now, if that is okay for you. But first, I'm going to start my presentation again. Voila, here we are. Okay, a question that I receive so often, yeah? Isn't there an alternative for friction massage? Friction massage is boring, is hard work, is tiring, and we have to be realistic. Yeah, when I do friction massage with patients, yeah, I do it for about 20 minutes. But let's imagine I have an Achilles tendon patient now, and my next patient is a tennis elbow, and my next patient is a supraspinatus. I feel my hands. It's quite a lot of effort. So are there alternatives? And the good news is, yes, there are alternatives. That doesn't mean that I don't do friction massage anymore. No. The effects of friction massage are pretty known. There are interesting, good physiological effects, but okay, it's hard work. But an alternative would be percutaneous microfenestration. And I don't know if anybody in the group over here already heard about that. Just share it with me in the chat if this sounds familiar to you, yes or no. And when you put something in the chat, there's always some digital delay. So when you write it down, then it takes more than a few seconds before I can see it in the chat. But if you would say percutaneous microfenestration, this is not 100% clear for me, then I understand that. Well, I have good news. Let me share my screen with you, and then I'm going to show you something live. If you go to our main website, cyriax.eu, you not only find information about our events, but you scroll down until you see this here, the knowledge bank. And this is a kind of new orthopedic medicine Wikipedia, so to speak. You click on the knowledge bank, and then you see a number of different sections. And in this section over here, complementary treatment techniques, I posted 6 articles, and one of those articles, what is percutaneous microfenestration? Well, in this article written by our colleague from Latin America, Mr. Pablo Romero, he gives here a very nice overview of what exactly is that, what are the effects, what are the indications, what are the contraindications, and surely many of you are going to think, oh yeah, he's talking about dry needling. Well, no, we are not talking about dry needling. Dry needling is another kind of procedure. And in this article, there's also a clear description of what is the difference with dry needling and percutaneous microfenestration. So you can find it here on the website. When you have some time, just have a look at it. But I think this is pretty valuable. Okay. Good. Well, that's one alternative. Actually, today I was also expecting our teacher, Mr. Sojo from Bangladesh, to be my co-host today, but apparently there is some technical problem, because normally he would appear here in the screen, but I don't see him. So If you are there, Sojal, just let me know in the chat, because he can also talk to you about other alternatives, also kind of needling techniques, but in combination with electrolysis. And that seems to be also pretty interesting when we talk about tenderness problems. Okay, so as I showed you, you go to the website, you go to the knowledge bank, and there you're going to find a lot of interesting information. Okay, I have a question for you. Good. Next poll. On the right side of your screen, you see a question. A shifting pain in the lumbar spine is typical for a facet joint dysfunction. True or false? Let me know. Let's play. Yeah. And the scores are varying. Yeah. Apparently, many people believe it's false, but still 20% of the people, 26%, 30% believe it's true. So, okay. Well, the correct answer is false. Yeah. A shifting pain in the lumbar spine is absolutely not related with a facet joint dysfunction. Yeah? And that's something I can illustrate in this way. Let's imagine somebody has back pain, central back pain. And then the back pain moves more unilaterally, and perhaps it moves more in the gluteal direction. And then the patient gets radiation into the leg. That happens all the time with back patients. We see that all the time. But then, when we analyze the history of the patient, what do we see? That his back pain, his unilateral back pain or gluteal back pain disappears, and he just has leg pain. So this is a clear shifting pain. And a shifting pain is, in the absolute majority of the cases, a shifting lesion. And there's only one thing that can shift in the spine. And what would that be? That's an internal derangement. Some kind of disc deformation, disc protrusion, disc bulging with pressure against dura or against the nerve root. So a facet joint problem, this only causes unilateral pain, not too much radiation in the leg, but it stays unilateral. A unilateral structure only causes unilateral pain, never is going to cause any central pain. Yeah, so keep that in mind. So a shifting pain is mostly related, in the absolute majority of the cases, related with a shifting lesion. Okay? Good. Well, I have another task for you. Let's have fun today. A painful arc on straight leg raise points in the direction of a bigger internal derangement. So, what do you think? Oh, it's exciting again. Yeah. Yeah, what do I mean with a painful arc? The patient is doing the straight leg, or we do the passive straight leg raise, no pain. Certain moment the patient has pain. We continue and the pain disappears. Okay. Well, it's interesting to see your reaction. Yeah? It's about 50-50. Yeah, about half of you say it's true, the other half says it's false. Well, let me help you on this one. It is false. A painful arc, when you find a painful arc on straight leg raise, you may be sure that the patient has an internal derangement, a small internal derangement, and that the patient certainly doesn't have a psychogenic problem. But painful arc on straight leg raise, painful arc on flexion in standing, always points in the direction of something small. And this is very good news, because when it's something small, it's going to be pretty easy to reduce that by using some manipulation technique, mobilization, traction, exercise, whatever. So keep that in mind. But I got also some other questions here about straight leg raise. I have to watch my paper. Where is the question? Here. Somebody is asking, if the straight leg raise is positive, where can I expect the location of the pain? Will it be gluteal, center of the back, or can we expect radiating pain? I am aware that hamstring tightness can restrict the straight leg raise range of motion. I have seen people with normal myotomes and dermatomes, but the pain in the gluteal region on straight leg raise. Can we still consider it as a discompression on sciatic nerve? Thank you. And a little notice, I'm quoting, I'm a big fan of you. Great, thank you very much. Okay, but this is also an interesting question. Where can you provoke pain on a straight leg raise? In the back, central back pain, unilateral back pain, gluteal pain, leg pain. Everything is possible, because people sometimes forget that straight leg raise is not just a test for the nerve roots L4, L5, S1, S2, but it's also a dural test. Yeah. So keep that in mind. But again, to help you a little bit further, I'm going to share my screen with you again. Voila. And then we go again to the knowledge bank. And in the knowledge bank, I have a series of articles here about functional examination and clinical reasoning strategies. And in one of those articles, but I have to look for it here, 7 things you need to know about a positive straight leg raise. And there's also a small film with it where I explain some key elements, but it might be interesting also to read this article. Here I explain in detail the clinical consequence or the clinical interpretation of a straight leg raise. So I give you a lot of homework, okay? Great. So let's go back to my slides. Good. In the meantime, when you have questions, don't be shy. Yeah, share your questions with me in the chat. Another question I very often get is, what is the best manipulation technique in the lumbar spine? Well, let me give you a pretty detailed answer again. For those of you who didn't do a live course yet, of course, all those things you learn during the live courses, but you also have another option, which I'm going to share with you at the end of this webinar. We also have the complete course content online, available in the online Ultimate Toolbox. But briefly, I'm going to say something about that later, but not too much. But you can find everything online. So, which is the best manipulation in the lumbar spine? And Sojol is saying a stretch manipulation. Of course, Sojol, the stretch manipulation, as you see it over here on this image, is going to be, yeah, let's say the most important maneuver. But I would like to share some important things with you about the strategy. If you manipulate elderly patients, if you manipulate patients with osteoporosis, don't perform techniques with a lever. I'll show you some examples a little bit later. And a second general rule, A patient with an acute lumbago, in other words, the patient has a big posterocentral internal derangement and he's blocked in flexion. If you ask to do him an extension in standing, the patient says, oh horrible, it's completely blocked and very painful. You're not going to do extension manipulation techniques with that patient because that would be a sadistic approach. So never do that, okay? In the meantime, I'm looking at the chat, which is the best manipulation technique? Well, no one is the best. I wouldn't say that. In a few minutes, I will show you that there are about 3-4 techniques. They are in my hit parade of being the most successful techniques. And then another question, some challenges in radicular pain, which is in distal more than the back. What to do to improve? Aha. This is also an interesting question. What do you think about that? It's all about biomechanics. I refer to the complete course on orthopedic medicine, the online and the live courses. Before you manipulate, the most important thing is selection criteria. Which elements from the history, which elements from the inspection, which elements from the functional examination are going to determine if that patient is suitable for manipulation, yes or no. And one of those elements is there more central pain, or is there peripheral pain, or is there more central pain? The more there is referred pain in peripheral direction, for instance, the patient has pain in his calf, but no more back pain. And let's imagine the patient is doing an extension in standing and you provoke this leg pain. This is what we call peripheralization. This is not favorable. You have about 30% chances to, let's say, reduce that by manipulation. Only 30%. The more central the protrusion, the more chances you have. But okay, I refer to our online and live courses to get the complete package. Saba is talking about rotation manipulation. Yes, I'm going to give you some examples. Most of the manipulations will have a rotational component. What can you do for a patient with chronic leg pain caused by internal derangement? I don't know. Orthopedic medicine is all about puzzle pieces, collecting puzzle pieces. I need the typical elements from history, from the inspection, from the functional examination. Then I'm going to put those puzzle pieces together, and then we're going to do clinical reasoning, and then we're going to try to reach some conclusion. So I need to know where his leg pain is coming from. Is it related with an internal derangement? Yes or no? Or is it coming from somewhere else? So first we have to determine this, and then we're going to determine strategy. Okay. If you decide to manipulate, let me first finish that little part, and then I'm going to come back to the chat, if that is okay for you. If we decide to manipulate, you do one maneuver. You never do what I call the manipulation cocktail. We're never going to do 5-6 manipulations at the same time and then see what happens. No, one maneuver. And then you check the positive test from the examination, straight leg raise, articular test in standing, whatever, and you see what happens. And if it gets better, never change your winning team, then you just continue. Yeah, you just continue with the same technique. But we don't have to be naive. It's quite possible that when you do the same technique 3 or 4 times, that the patient is better, but he's not extra better anymore. And then, of course, we have to change the technique. And what is the definition of a patient who gets better? Well, we have a nice definition. You retest the patient and he says, I have less pain or more range of motion or less movements are painful. Yeah, for instance, straight leg raise was positive, but now the straight leg raise is negative, but some other movements are still positive. Or the opposite of peripheralization, the centralization. Yeah, if the patient describes centralizing symptoms, whatever you were doing, manipulation, mobilization, whatever exercise the patient was doing, when you create centralization, it's always a very good idea. And the appearance of a painful arc. Remember the previous question? We were talking about painful arc on straight leg raise. This must be a small problem. Painful arc is never a big problem. Okay, and here we see a hit list or a hit parade list of our, the more popular manipulations. On the left side, you see the stretch manipulation. I'm not going to go 100% in detail now because I want to talk about other questions too. But again, the full story, you can also find it online. You can also find some information in the knowledge bank I showed you earlier. But mostly we do the stretch. We move to the second maneuver, which we call the leg over. You see that's a technique with a lever. Don't do this technique with elderly patients and with osteoporotic patients. Yeah. And then the third technique, this is a kind of leg over manipulation with a built-in side flexion. And then on the bottom row, we have two more options. We can do an extension technique or what we call the light blue arrow, the reverse stretch manipulation. Okay. Let me have a look at the chat, because in the meantime, I saw some other questions are coming in. What can you do in spondylolisthesis patients? Good question. The question is, the patient has problems, but are the problems related with the spondylolisthesis? That's the million-dollar question. In the majority of the cases, you see the spondylolisthesis on medical imaging. 1 + 1 is 2. No, 1 + 1 is 3. It's not because you see that on medical imaging that spondylolisthesis is also responsible for the problems. Remember, the puzzle pieces have to fit. And there's a typical story about the spondylolisthesis. And those patients say they have problems on walking and standing, which disappear within 1 minute on sitting and lying. And this is a totally different story in comparison to the patients with a lumbar internal derangement. So it's perfectly possible that the spondylolisthesis is asymptomatic and that the patient has an internal derangement. Only when the history is there, one more time, pain on walking and standing, which disappears on sitting and lying. When this is the problem, and they have a big spondylolisthesis, then the solution, unfortunately, is just surgery. All the rest is irrelevant. Saba is asking, in case of disc issue, can we do rotation manipulation like if it's acute and not much? Well, I refer to the indications and the contraindications of manipulative treatment, which are also described in the course handouts and the online platform and the knowledge bank. If it's too acute, if a patient can barely move, and if a patient needs a few minutes to get from sitting to standing position, and every movement is causing a lot of twinges, manipulation is not going to be the best idea at this moment. We have to wait. Maruf is saying it depends on physical and also psychological status of the patient. And yes, on my online masterclass, the online toolbox, I have a complete chapter about understanding chronic pain and the actual scientific views on chronic pain and understanding pain, and the relation between pain and what's happening in our brain. And every one of us is reacting on pain signals in a different way. So yes, the psychological status of a patient can be very important. You can have a mechanical, interesting lesion to treat. It looks perfectly, but we have some, let's say, psychological contraindications, and then we have to look at the patient from a different perspective. Yeah. Remember, back pain is not always purely mechanical. Yeah, we have to look at the biopsychosocial aspect. A question that also was asked by one of you here on my list. Somebody is saying, clear image of a small lumbar internal derangement, partial articular pattern, slight dural symptoms and signs, no neurological deficit. It's clear that this person already followed our course. The patient complains with pain on the left side of the lower back, but the straight leg raise is painful on the right side. Yes, that's possible. When you're going to read this article about 7 things you need to know about the straight leg raise in the knowledge bank, then you see we're going to talk about a crossed straight leg raise. So it's possible that a left straight leg raise is causing pain on the right side. Yeah, perfectly possible. But the question continues. So the straight leg raise is painful on the right side and pain-free on the left side. I decide to perform the stretch manipulation, the first manipulation you see on the picture, left top. Should I perform it with the painful side up or the positive straight leg raise side up? And this is a beautiful question. Yeah. We always start this strategy with the painful side up, and we see what happens. And let's imagine that the patient has bilateral pain. Then I look at my straight leg raise, and let's imagine that the straight leg raise on one side is more painful or limited in comparison to the other side. Let's say the left side is more painful. Then I put the patient on the right side, so with the left side up. But this is not a golden rule. As you can see on this slide, sometimes we're going to do it differently. If the stretch maneuver with the painful side up doesn't give you satisfying results, then you try exactly the same with the painful side down. And actually, that's also what Mackenzie is doing with certain of his treatment techniques. It's the same logic. Yeah, why are those things sometimes useful? Because we just play and change intradiscal pressures. So to answer to your question, there is no golden rule. Start with one side, see what happens. If it gets better, you continue. The moment it doesn't get better anymore, you choose another technique or you put the patient on the other side. Okay? Then Saba is asking, it's contraindicated in spinal stenosis manipulation? Yes, of course. But again, the same answer as I gave you for the spondylolisthesis. Is the spinal stenosis symptomatic, yes or no? Because the story of a spinal stenosis patient is totally different than the story of an internal derangement patient. Most of the spinal stenosis we see on medical imaging are, the absolute majority are asymptomatic. Only when the story is there, and one of the typical elements in the story is that they have intermittent claudicatio on walking. They walk a certain amount of time, they get back pain, leg pain. They have to stop because it hurts too much. They have to sit. They wait a few minutes, they can walk again, 300-400 meters, they have to sit again. They walk again, 300-400 meters, they have to sit again. Yeah? This is typical for spinal stenosis. Of course, we don't think of manipulation. And what's next question? Well, I'm happy with your questions. What can we do for radiculopathy in a young female patient aged between 25 and 35 years having sacralization? Well, first of all, sacralization, I don't care. This is, okay, let's say a pathological deformation, but this is, in the absolute majority of the cases, totally irrelevant, is not symptomatic. So if her leg pain is related with an internal derangement, which is likely, and because she's so very young, young patients seem to react better on mechanical traction treatment, and they don't react that good on manipulation treatment. And because you asked that question, well, let me share my screen again with you. Yeah, perfect. And I go back to the knowledge bank. And let me think. I go back to this section, functional examination and clinical reasoning challenges. No. I have to go to another section. Complementary treatment techniques. No. I put so much information online that sometimes I forget where I put the information. Sorry about that. Haha, here it is. When to apply mechanical traction in the lumbar spine. Well, you have here the complete recording of one of my previous webinars where I explain in detail how you apply mechanical traction, indications, contraindications, the whole story. Okay, so if you're interested in this element, I surely advise you to have a look at that. Okay. That goes nice. Good. Let me have a look at the chat again, because there is quite a lot of activity. Yeah, Saba is asking, what is the preferred treatment for a patient who is having back pain and recurrent SI pain? SI pain causes back pain in such case, how to treat that kind of pain, and also have a history of discal pain, which is fine now. Yeah, okay, Saba, I'm going to refer you to my online masterclass and to the live courses, because then I have to talk a few hours to explain that. You have many patients with gluteal pain in the SI area, but a real SI problem, a real symptomatic SI problem, is extremely rare. Although half of the planet in the musculoskeletal world and manual therapists, they still believe that things like sacroiliac hypermobility and all that kind of stuff that exists. But unfortunately, I'm going to be very undiplomatic. This is one big illusion. There is more than enough scientific backup for that. But I refer to my other courses. Arafat is asking, what can we do when a patient has anterior thigh pain without having back pain? Yeah, he received vitamin D. Yeah, okay. Yeah, again, I have to give a similar answer as before. This is the problem of many therapists. Many physios, many doctors have the same problem. We look at one thing, he has anterior pain on the thigh. That's it. and perhaps one test is positive, that's it. That doesn't help me. That's completely useless for me. I need his story. I need the inspection. I need a good functional examination. I need to collect puzzle pieces and put the things together. That's why we developed also a series of assessment forms. For each joint, we have a standardized assessment form to make life easier for you and for me, so that when we examine a patient, that we don't miss things. Also, during our courses, we teach you how to work with the assessment form, and also in the knowledge bank and on the online masterclass, there are some films about how to use an assessment form. Okay, I have another challenge for you. And where is that challenge? That's an interesting one. What do you think of this one? A tendinitis, shoulder tendinitis, elbow, whatever, knee, hip, never causes limitation of passive movement. Whoa, the scores go up and down. Interesting to see. Yeah. Well, a tendinitis never causes limitation of passive movement. This is true. Never. It is possible that a patient has limitation of active movement because of the pain, but when you take over passively, you're never going to have passive limitation. It can be painful. Oh yes, it can be painful, but you're not going to have passive limitation. So, moral of the story, when you have passive limitation of movement, this is not related to the tendinitis. There must be another reason for this limitation. Yeah? Nice to know. Let me see if I have another challenge here for you. The pulse. Yeah. What do you think of this one? A painful arc in the shoulder is an impingement sign. And the scores go up and down again. Very nice. So what do we mean by impingement? Something is squeezed in temporarily between humerus and acromion. Of course, a painful arc in the shoulder is something which is very, very common. And what is the score? 2/3 of the group is saying it's true, and 1/3 of the group is saying it's false. Okay. Now we go to 68% true, and the correct answer is true. But that doesn't help us too much, because the diagnosis impingement syndrome, this is a non-diagnosis that just says something is squeezed in the shoulder somewhere, but you don't know what. Is it the bursa? Is it the supraspinatus, infraspinatus, subscapularis, biceps, acromioclavicular joint? We don't know. Well, let me share my screen again with you. And we'll go again to the knowledge bank. And we go again to the section of complementary treatment techniques. And then here, I have an article about the actual views on tendinopathy. So when you think of tendon lesions, this is a PowerPoint podcast that takes about 40 minutes or so. then you're going to understand tendon problems in an easier way. But there is something else I can show you. We go to another section. We go to the clinical reasoning section over here. Okay. What about shoulder impingement tests? And this is also a nice PowerPoint podcast. It's also half an hour or something like this. So I give you here a lot of valuable information. Here you can discover which extra test could be useful when you think about a so-called impingement. Okay. Yeah. Good. A question here about the shoulder. Acute shoulder problem. If we do any tests, they all will be positive. So what to do not to fall into these false positive trap, so to speak? Well, I never said orthopedic medicine is easy. No, it's a challenge. And indeed, tests can be false positive and false negative. So how do we solve that? Repeat the test several times. Repeat the test on several occasions. Compare left and right. And then you're going to see which are the consistent positive tests and which are what I call the radio disturber test. Yeah? So that's a simple trick, but sometimes you have to retest on several occasions. Okay? Good. Another question, because I still have a few questions for you, 3 or 4 questions at least. But a question I also often get through email is, how can I get a diploma? Yeah? Many people like to follow our courses, but also many people, they like to receive the certificate, and I understand that. But many people would like to go further, would like to explore their possibilities and really go into the depth and really get the most out of it. And then they ask, how do I get my diploma? Well, I'm going to give you a very, very short answer. Together with my team, also Sojol in Dhaka, Bangladesh, we teach courses in more than 40 different countries. You just go to our website, cyriax.eu. You have a look at modular diploma course, and there you find all the information about our courses. If you need more specific information on dates and locations, you just fill in the contact form, you contact me, and I bring you in contact with the specific teachers, local teachers we have. Okay? Another option is that you come over here. Yeah. Over here. Whoops. Wrong button. Voila. Over here where I'm now. I'm here in the ETGOM GCI International Training Center. So it's here that I offer a few times per year the Mastermind private training. It's an intensive 7 days training. You also find all the information online. This year the groups are full. So if you would have interest in joining a mastermind, then that's possible, let me think, from 6 to 12 May 2023. Yeah. But as I told you, you find everything on this link. And where am I located? Well, I'm broadcasting now from the Belgian coast. It's summertime over here, but today the weather is not so spectacular. We had a very nice period with a lot of sun, and tomorrow the sun is going to come back. But I'm very close to the beach, and the people who know me, they know that I have to see the sea every day, of course. And together with my guests, we have a 7 days, very intensive program, but you can't come to Belgium without enjoying the Belgian chocolates, of course. But don't worry, we work 7 days pretty intensively. And perhaps, who knows, one of you is going to be my next guest. Okay, but let me have a look at the chat again. Painful arc is a shoulder impingement syndrome. No, a shoulder impingement syndrome. This is shoulder impingement. Then I refer to the things I showed you in the knowledge bank a little bit earlier. Shoulder impingement is a statement. Something is squeezed in the shoulder temporarily. But you don't, that's not a diagnosis. Yeah. A painful arc, and now we go a little bit further. A painful arc can be related to a supraspinatus problem, infraspinatus problem, subscapularis problem, bursitis problem, biceps problem, acromioclavicular joint problem. Yeah, all those things, of course, you learn during our courses and also in the online platform. Yeah, it's quite a lot of details. And Saba is asking, sir, can we come to Belgium for certification or diploma? Well, it's simple, both. Yeah, you come for both. But if you have more interest in this program, just send me an email or just go to the website and you see the contact information over there. Okay. I have another challenge for you. Let's close this one and open the next one. Reset poll. Yes, I love the technology. Yes. What do you think? What do you think of this question? Twinges, giving way, and blocking are typical in the arthrotic knee. And there we go again. So I'm really happy that you contribute so much. That's really super nice. Yeah. And how is the score evaluating? About 50-50. Yeah. Well, 50. No, it's really about 50-50 now. Yeah. Okay. The correct answer is false. Arthrosis doesn't cause twinges, giving way, and blocking. No. If you're lucky, arthrosis causes pain in general, but not those symptoms. Those symptoms are typical for an internal derangement. And what is an internal derangement in the knee? That could be some kinds of meniscal problem, but that could also be a loose body problem. And typical for a loose body, an internal derangement in the arthrotic joint is the fact that your patient is saying, I have twinges, I lose control over my knee, yeah, and sometimes my knee blocks. Yeah? This is typical. So most of the therapists, yeah, they see the arthrosis. But you hear the internal derangement in the story. And mostly you don't see that on imaging. Yeah, if you would see that on imaging, then that would be bony loose bodies, and then there's only one solution, arthroscopy, because bony loose bodies in your joint, this is not the best idea. But if you have non-bony loose bodies, which you just hear, we have a nice manipulation technique for that. Works very fine, works very fast. And one of the people who registered for this webinar also asked me, how can we improve and diagnose knee osteoarthritis? Well, first we have to determine what we are talking about. Do you talk about arthrosis or do you talk about arthritis? Arthritis is an acute inflammation in the knee. Arthrosis is absolutely not acute. With arthritis, you're going to have quite a lot of swelling, quite a lot of symptoms. And you're going to have a very nice capsular pattern. And for those of you who didn't follow the course yet, capsular pattern in the knee is limitation in two directions. Flexion is more limited than extension. When you find that pattern, that goes together with arthrosis or arthritis. But again, orthopedic medicine is all about reaching a valid diagnosis. And then we're going to set the treatment. And yeah, when you talk about an arthrotic patient, what are you going to do with Cyriax techniques? Manual techniques? Nothing. An interesting approach is, for instance, an injection, an intra-articular injection with hyaluronic acid. Also about injections and hyaluronic acid and so on, you find a lot of information in the knowledge bank. Okay? Good. How can we use assessment in acute patients with severe pain? We just use it. We have our history, inspection, functional examination, and of course with an acute patient, your test result is going to be pretty different than with a chronic patient. More tests are going to be painful, limited, and so on, but you just do your normal test protocol as it is described on your assessment form. Let me see if I have another challenge here for you. Yeah. What do you think of this one? In an acute shoulder arthritis, I will do capsular stretch treatment techniques. Your question comes on the perfect moment. Yeah, talking about acute patients. Yeah, I love those polls. And again, you are a challenging audience. Yeah, fantastic. Yeah, it's again 50-50. Okay. What can we learn from that? Well, let me help you a little bit. If a patient has a shoulder arthritis, you find the capsular pattern. What is the capsular pattern? Lateral rotation is more limited than abduction. Abduction is more limited than medial rotation. This is the capsular pattern. Okay? But we describe 3 stages in arthritis. Stage 1, 2, 3. Stage 1, we call that an arthritis light. Stage 3, an arthritis heavy. But how do we come to this conclusion? Well, in the history there are 3 questions which are pretty important. Is there any radiation of pain that goes further than the elbow? Can you lie on that side? And do you have any pain at rest? Keep in mind those 3 questions. Okay? Now, what do we do with those 3 questions? If you have 3 favorable answers, so in other words, no radiation below the elbow, you can lie on that side, there is no pain at rest, then we have a stage 1 arthritis. We call that the light. If you have 3 unfavorable answers, I have pain at rest, there is a lot of radiation, I can't lie on that side, that's an arthritis heavy. And you see that the treatment strategy in the light version is totally different than the heavy version. Totally different. In a stage 3, you're not going to do pretty intensive exercises. You're not going to do stretching techniques. Stretching techniques, end range mobilization and stretching, that's only for a stage 1. Yeah? More specifically, as you see here, this is one of the options in a stretching technique. which you do about 15-20 minutes. You combine that with home exercise. Yeah? You provoke some after pain. With this kind of technique, you can say no pain, no gain. Yeah, you have to hurt the patient a little bit. But again, more information about that in my other webinars and my online courses. And again, you find a lot in the knowledge bank. Stage 3, we can do injection technique, or we can do some manual distraction technique. But at this moment, it's too acute. You can't do certain exercises. Okay? I can imagine that, okay, I promised you the webinar would take about 1 hour, so it's already 1 hour. So slowly but surely we're going to conclude, because you still have some other things to do today, I imagine. You will have more questions, yeah, of course. That's logical. I'm offering you a rescue service. Go to the website, go to the contact form. Whenever you have a question, whenever you have a problem, fill in the contact form. When you fill in the contact form, you're talking to me. All those messages, they are coming directly to me. And if I can help you, I'm going to help you with pleasure. It's part of my mission to help you, because I want that you become more successful in orthopedic medicine, that you have the same fun as I have, the same passion, yeah, because it's all about passion. And believe it or not, but a few days ago, together with my wife, I was visiting some friends, some Belgo-Brazilian friends, because you know that my wife is also a colleague, but she's from Brazil. And the people who follow me, you know that my marriage is the result of teaching Cyriax courses in Brazil. Yes, Mr. Arafat, Cyriax is so romantic. I love Cyriax. Thank you for the chat message. Yes, it was that romantic that, finally I got married with my course participant. And when we visited the friends a few days ago in the garden, I saw this plant. And this is the flower of the passion fruit. And this is so applicable for our story today. What I do here for you, what I do with my patients, it's all about passion. And that's what I wish to you too. So knowledge without action is irrelevant. You can follow all the courses you want, and you can read all the articles you want, but if you don't do anything with it, it's hopeless. So my advice is, when you are not a guest yet on our live or online courses, do so. Yeah. Study step by step. Try to implement things in your daily practice. Whenever you have a problem, you know where you can find me. You know how to contact me. It's going to be my pleasure to help you. But again, knowledge without action is completely irrelevant. And which action could you take? Well, surf to cyriax.eu/yes. There is something special there waiting for you. I'm not going to say what. It's related to the online tools I developed for you. Just surf over there, have a look. And for those of you who would like to be my next guest over here along the Belgian coast, then you surf to Mastermind. Voila. So I think I have a good timing again, 1 hour, 3 minutes and 43 seconds. So that's perfect. I just have a quick look to the chat again. Thank you very much for your nice feedback in the chat. I appreciate that very much. That gives me the spirit to continue. The next webinar is going to be about clinical reasoning somewhere beginning of September. It's already announced on cyriax.eu. So if you want, you can already register for the next webinar. So I have one more question for you. Do you have any more questions for me? Because now is the moment. Okay. So thank you very much. I wish you a very nice continuation of your day, a very nice evening in Asia, a very nice midday in or morning in the Western world, or the far West, so to speak. Thank you very much for joining me today. Wish you all the best and see you on the next occasion. Bye-bye. Ciao.